Hello and welcome to CDA TV. Here is the first episode of a collaboration with Cancer Research UK, the Cambridge Resource Centre. So we have three guests here today. Dr Claire Goodchild. Hello. Second, Dr Raj Jena.
Hello.
And third, we have Susan Marsh. So we've got an exciting list of questions for everybody. Sorry. They're going to be sharing their knowledge and experience with us today about cancer and also about deaf cancer support and the research that's involved in it. So I'd like to ask Dr Claire Goodchild, you've been working with CDA for a while now. How has it been through Cancer Research UK and the CDA collaboration?
It's been fantastic. Thank you very much for inviting us here this evening. It's a great opportunity to share about the work that we've been doing and really excited about the work that we will continue to do. It started maybe about 3 or 4 months ago when we had a seminar given by a researcher who was looking at the health inequalities in the deaf community and presenting on how cancer patients who are deaf have a more difficult time, poorer prognosis, and it really inspired me to try and do something to change that. And we discovered through conversations with various organisations like Sign Health and especially with CDA about the fact that it's a lack of resources explained in British Sign Language. And whilst Cancer Research UK has really good resources about signs and symptoms and risk factors and treatments, we realised that they're not accessible to the deaf community. And so we really wanted to start by developing a relationship with the deaf community and be able to build those resources that are accessible and to help make the patient experience better. And that's really excited to be able to start doing that with you.
And Raj Jena, would you like to explain a little bit about your role and what you do?
Thanks. I have 2 jobs. I spend half my time as a cancer doctor, and in the cancer centre I look after people with brain tumours in particular. This is very relevant for me. I look after a group of young patients who develop lots of tumours in different places in the brain and are very likely to go deaf. So I'm interested in offering treatments like drugs and radiotherapy as alternatives to surgery to help this group of patients keep their hearing for as long as possible. The other half of my time, I do research in artificial intelligence. And there are lots of tools that we build in artificial intelligence that start to influence the way that we share information with patients and make decisions together. So I'm very interested in that side as well.
Fantastic, thank you. And over to you, Susan. Would you like to explain a bit about yourself and your work? Yes, thank you so much, Cancer Support Project. So we signed this. And it's funded by Macmillan since 2022 until now. And it's a national service that covers all of the UK. And I'm an advocate for deaf cancer support, but obviously today I'll be talking on behalf of the whole service. Brilliant. So looking to the audience, if you're watching live, maybe you've got some questions to ask, please do share your questions, your views, pop them on Facebook, and I'll pass them on to our guests. So my first question for you both, when a person is diagnosed with cancer, what's the sort of typical journey? What does it look like from that initial diagnosis?
Well, you, as a doctor, probably better to answer that.
There are 2 ways. We would like people to be picked up through some kind of screening program. So in other words, you engage in a set of checks to see if there may be signs of a cancer developing at its earliest stage. And you would know about things like breast cancer screening and cervix cancer screening, but there are many other good screening programs coming up across the country. That's how we would like patients to present if they are unfortunate enough to get cancer. Sadly, in the UK, too many people present with cancer in an emergency situation. That means they come to the emergency department of a hospital with something wrong, and they then go on to discover that it's due to a cancer. And we know that if you present in that way, the outcomes are not as good as if it's picked up early. So those are the two ways that people tend to present with cancer.
Brilliant. So you were saying that lots are sad in the UK, lots are diagnosed later. What is it? Why is that diagnosed later at that emergency stage, do you think?
Some types of cancer, the way that they cause symptoms, the way they present, is very similar to things that you might experience anyway. And there it's very difficult to have the knowledge to know that something isn't wrong. For example, brain tumours, they present with headaches quite often. Well, everyone gets a headache from time to time. So how do you know when it's a headache that's okay or it's a headache that's a warning sign? These are subtle things. Then there are other times, for example, if you've got a cough, it's okay to be having a cough for a little while, but if you cough up some blood on your hanky, then you probably know there's something wrong and you would seek attention. So it's really about working with people, about understanding what we call the red flags, things that you mustn't ignore, that could be, not always, but could be signs of having some kind of cancer.
Brilliant. Thank you so much for sharing that. Oh, can I just interrupt there? So for me, working in the deaf community, the late diagnosis is often, as you say, because they don't understand, and they might not understand how important the screening is as well. They might just think, oh, I can't be bothered, or it's not important. But actually it's so, so important. If you receive that letter and to find you have to go for that appointment, please, please do go. It's so important. That could be your lifesaver, you know. So I think for the deaf community especially, don't ignore those screening letters. Interesting. So with the deaf community, do you feel that we have enough information out there in BSL about recognising the signs or symptoms of cancer, or do you feel there's not enough sort of understanding? Two things really. In some areas, yes, there's not enough information. You're absolutely right, it's just not accessible. In other areas, I think people know about it, but they're not very receptive to it, so they prefer not to sort of engage. So it sort of feels like a bit of a taboo subject for a lot of the deaf community. Interesting. I'll clarify with you then, Claire, with your team. When you initially get involved in supporting a deaf patient, how long? Is it just after the diagnosis, or how long do you support someone for? For us, it varies really. It could be that they contact us within 24 hours of a diagnosis. Or it could be right at the sort of end stages. It really depends, or anything in between. I don't want to sort of go into too much details about the stages, of course. I'll be here all night. But if you are happy to contact us, we're happy to explain the different stages as well if you're struggling with those, with understanding that, and understanding that sort of early diagnosis to that late diagnosis as well. And no disrespect to the NHS services at all, but the late diagnosis, they have to go through this long process of elimination to say, okay, it's not this illness, it's not that illness, it's not this, okay, actually, yes, it might be cancer. So sometimes it does happen like that. It's just the processes they have to follow. I'm sure you'll agree. Yeah, it seems like they both agree. So what would you do with the deaf person? Would you support them emotionally? What does your work involve when you connect with that person who has cancer? So there's a team of us. We have an advocacy team, which is me. And so really I'm involved to make sure interpreters are available at the hospital, to make sure that the standards are good, to make sure that they have the right treatment as well, and to make sure that they understand the treatment that they're consenting to make sure they have benefits available, because obviously some areas, for example here in Cambridge, they have benefits advice for deaf people, but some areas don't have that, so I can step in to help with that. And we can fast track on benefits as well because of the cancer support, especially if it's terminal, sort of end of life. Oh, sorry, would you like to jump in there?
I was just listening to what you were saying, and you're doing several things together as well as being an interpreter. You're acting as the patient's advocate. And actually, for most patients, they have to find different people to do those things. So it's really good if you have the same person doing several support roles, because the relationship and understanding is much stronger. So that's a very good thing, in fact, compared to many other people accessing support in our cancer centre.
Oh, thank you. That's lovely to hear. We also have a peer support service, so they look after the clients for the emotional support, like you mentioned. So that might be one-to-one chats with the person, it might just be sitting and listening, and help with signposting as well to different services. And we have a bank of volunteers that work with us who also deliver emotional support, and they have the potential to do different things. Oh, lovely. Thank you very much for sharing that. And so I'd like to ask you, Raj, if someone's diagnosed with cancer, the next step of going through the sort of potential treatments and the different sites of therapy, I know there's different sorts of immunotherapy, chemotherapy, radiotherapy. What is the differences between all these therapies, and how do you work to decide which one's going to be the most beneficial for that patient?
Very good question. It's different for each type of cancer that we have. But one thing remains the same. For every person where we think they may have cancer, they would always be discussed in a meeting where the people that can offer each type of treatment sit and talk together, so that you get the best opinion on when to use surgery, when to use radiotherapy, and when to use drugs. That didn't used to happen in the bad old days. And in the bad old days, if you were diagnosed or with suspected cancer, you would go and see a surgeon, because the surgeon would have to get a little bit of the tumour to find out what it is. And then the surgeon would be the person that decided which path you went to your treatment. But it's really nice now that we all work together, and those discussions happen with all of the experts together, and quite often now with the patient there too, which is really good, as it should be.
Can you explain the difference between chemotherapy and immunotherapy, for example?
So, drug treatments for cancer have really changed over the last 50 years. We started with drugs that just attacked cells that were growing quickly. And cancer cells generally are growing. They're trying to get bigger all the time. So these drugs tended to have more of an effect on the cancer cells than every other part of the body. But boy, they still made you very sick. As years have gone by, we've started to develop drugs that are better at targeting the cancer and have less effects on your healthy body. These drugs are much easier to take and much better tolerated. So we move from these older chemotherapy drugs to these new targeted drugs. And immunotherapy is just the next step. Immunotherapy just means a drug that allows the immune system to recognize a cancer that was hiding in your body. the immune system is so powerful at getting rid of things in your body that shouldn't be there. And that's how these drugs work, because the tumours learn how to hide from the immune system, and they basically stop them from being able to do that. And that's why it's so exciting to see how these drugs can work incredibly well, even when patients have got very advanced cancer.
That's really interesting. So I'm just wondering about immunotherapy. What are there side effects to having that then? Because you mentioned about the side effects of chemo.
There are, and it's important to know that they're quite different from the side effects of chemotherapy. So if you or somebody in your family has previous experience of somebody who's had treatment for cancer and they had chemotherapy, and suddenly you or a member of your family is being offered immunotherapy, then what you knew from the chemotherapy doesn't apply to immunotherapy. The best way I can think about describing immunotherapy side effects is that they turn up the volume too much on the immune system. So the immune system, as well as learning to attack the tumour, starts to attack parts of the healthy body too. And we can easily turn that down, but you need to be able to recognise when that's happening. And that's what we do. We talk to patients who are about to start immunotherapy to help them recognise some of these things. And some of these things we just test for. They're a very easy test to do in the blood to see if that attack is starting to happen and stop it at the early stage.
So with your research, how do you sort of research into developing these different sorts of drugs to create fewer side effects? Because I'm wondering with the therapies, obviously, can it affect things like deafness or other illnesses?
It's really nice to leave chemotherapy behind, because some of those drugs were terrible for causing deafness. And not only deafness, but problems with vision and problems with your sense of touch too. The newer drugs are much better from that side of things. And some of the clever tricks they use at the cancer centre to design new drugs are ways of making lots and lots of cancers that are all different from each other in the lab. And so they can take a sample donated from one cancer patient and they can turn it into hundreds of different tumours and then test thousands of potential medicines against hundreds of tumours. They do that with artificial intelligence, and to me that's one of the really exciting ways to use AI as a tool for cancer research.
Wow, so how does that work with the AI? I'm really curious.
So AI is really good at reading information from humans and looking for patterns. My AI is interested in looking at cancer images, but in this case, the AI is reading the genetic code of the tumour and looking for patterns. Because it can do that, the AI gets very good at making copies of tumours based on the patterns it knows. It's making fake tumours, but the fake tumours are very, very realistic enough to test new drugs.
Wow, how amazing. So, wonder if a deaf person's diagnosed with cancer, it can feel really like an overwhelming journey. So I wonder, how would you support them through that journey or that stage? What sort of support would your team offer, Claire? Susan. So just to be clear, we won't offer medical advice, but we could support with anything, any questions that you ask us about the cancer. We will do our best to break down the information. We can explain it in different ways, and we can make recommendations through discussions. Sometimes patients come to us and they say, I'm not happy with the treatment I have to go through. And we can go through the other options with them, but we always encourage them to talk to their oncologist. That's really, really important to have that medical guidance, because they are much more experienced and have the expertise that we don't have. So we might signpost or support them to go to different places. So they might get grants from Macmillan for a wig, for example. And sometimes, unfortunately, people do get diagnosed and they say, you have cancer, here's a book to read about it. And obviously a lot of deaf people walk away completely overwhelmed, because obviously the English and the jargon in it especially. And so sometimes we can get them to sort of put aside the book, and we can actually just chat to them through our knowledge and our experience and support them through that diagnosis to make them feel a little bit more positive and face what challenges they are going to have. Oh, so when you said a deaf person's diagnosed with with cancer, and they access your service for support, you will offer them information and share that discussion with them and listen to them, but you won't give the advice, because that's for the healthcare professionals. Is that right? What about for deaf patients? Do you feel there's a specific area? I think at the end of the day, we will always need the interpreters there at the appointments. We need the healthcare the healthcare professionals to be booking the interpreters, because they need to understand the importance of communication support. It might be that somebody needs a lip speaker, or they might need deafblind manual hands-on signer. And so it's really, really important to be aware to book interpreters for all of the appointments for a deaf patient. I absolutely agree with that. I think we're in a generation now where technology is developing a long way. So do you feel like maybe there could be things like, if they're given a book, a QR code, for example, with a BSL translation? Because obviously, as well as booking an interpreter, I'm just wondering, Claire, do you have anything to add on that?
Yeah, that's one of the things we'd really like to do in the centre is that information, that book of information you get in a cancer diagnosis for a hearing person is often hard enough to read through. There's lots of jargon, there's lots to understand, and when you are having that emotional experience of being diagnosed with cancer, it's really hard to take that information in and try and understand what you're being told. So one of the things we're doing in the Cancer Centre is to try and make that information more accessible by making it into things like animations, short videos where they're interpreted into other languages, and we'd like to include British Sign Language in that, so that actually that information is readily available to the deaf community as well as to other communities that we serve in the east of England and across the country.
Brilliant. I think that's so important, and it's about building that trust as well with the deaf community, and knowing that the healthcare professionals are kind of working together with the community. So it means that in the future, like Susan was saying, some deaf people, but obviously a lot of people sort of get a bit defensive and they don't want to believe that they've got cancer, but they're able to approach you and they're able to be confident. So hopefully the deaf community can do that earlier on as well.
I mean, one of the things we're planning on doing, and actually that's work we're planning on doing with the Cambridgeshire Deaf Association, is to put together an awareness campaign aimed at the clinician to help them to identify small changes they could make in the way that they do their practice that would make a deaf cancer patient's treatment better overall. So it could be simple things like making sure that there is good Wi-Fi access so that remote interpreters are easy to get hold of and to be able to keep a conversation going quite easily. Things like having the room set up so that the interpreter can sit next to the clinician rather than next to the patient, and making the conversation with the interpreter better. And also things like not turning around to type on your computer whilst talking to a patient who relies on lip reading, for example. So just small changes like that could make the overall experience of a patient much better. And so we're trying to make clinicians aware of that and to encourage those changes in clinical practice.
I wanted to add as well, one of the things that you were talking about the different generations that might be experiencing cancer. So for the older generation, when you say to them, oh, you know, you've got cancer, lots of people go, oh God, that's it, I'm dying, you know, and it can be really hard. But I know some of the younger generations are much more reactive, and they sort of thinking more about, okay, what can I do? What treatment's available? So there's a difference in ages as well. That's really interesting. So Claire, you mentioned about deaf awareness being very important. So I think you explained last week you had some deaf awareness training for your team. So did you learn a bit of finger spelling as well? Is that right?
I did, yes. Yes, so one of the things we really like to do in order to be able to provide that interpreted resources is to work with deaf patients, with deaf advocates like Susan. And so it would be bad to do that and have a deaf person come and work with us if there was no way of communicating with anybody else that they worked with. The last thing we want is for anyone to feel isolated within our team. So I have 17 members of our programme management team who are all learning British Sign Language. And last week, Andy and Lauren from the Cambridgeshire Deaf Association came in and gave us a lunchtime session learning the alphabet, learning to spell our names, and common greeting signs and things like that, which was fantastic. Everybody absolutely loved it, and we're really excited to continue learning British Sign Language. I'm also hoping that I can convince some of the team, including myself, to volunteer with the befriending service and to come out and just do some volunteer work with the Cambridgeshire Deaf Association to be able to build that relationship, to build the trust that you mentioned earlier on as well.
Oh, definitely. I think it's been a great start as well, building that relationship with us at CDA and developing for the future. And it means that deaf people can see people around, and they're noticing that the deaf awareness is improving. And even things like finger spelling with us, it will just build their confidence in approaching you. So, Raj, I'd love to ask you a little bit more of an in-depth question about the nerves that are affected by the brain tumours. We had a brief discussion earlier when you said it can affect the hearing nerve. So could you explain a little bit more about that?
Yes. There are a range of tumours that tend to grow by wrapping themselves around nerves, both in the brain and round the body. They are benign tumours, which means that they can't spread to any other part of the body. But by squeezing and squashing a nerve, they can cause an awful lot of trouble. So if it's wrapped around your optic nerve, it can make you go blind. And if it's wrapped around your hearing nerve, then you will gradually lose your hearing. These tumours grow very slowly though, and that means that we have a chance to make a plan with a patient that has either one or two of these, one on each hearing nerve, to think about how are we going to control the tumour and also preserve their hearing for as long as possible. Again, in the bad old days, you're going to think I don't like surgeons. Well, I do. But in the bad old days, the only treatment that we had for this was an operation. And to remove the tumour meant you'd have to cut the nerve and you would be deaf straight away. But what's wonderful now is that we have drug treatments and radiotherapy treatments that are just as effective as surgery, but you get to keep your hearing for longer. And as a result of that, people with these types of tumours, the number of operations, has dropped by 70%, which is amazing. And that means that we can do some very clever things. If somebody's got two tumours on their hearing nerves and they're growing quite quickly, then we can treat one with, say, radiotherapy and put in an implant so that the person can get used to hearing from the other ear through the implant. Then, when the other tumour needs treating with an operation to remove it, the implant is already there and working. And so that person is hearing through their hearing nerve that's been treated with radiotherapy on one side and the implant on the other, which is amazing to think that you can actually do that. So it's all about empowering people and giving them options so that they can make decisions about when these things happen and keep their hearing for as long as possible.
Wow, that's really, really interesting. So, sort of saying, like, reducing that impact, I'm assuming. So, when you obviously put in the cochlear implant, is that a big change? Is it very different for the brain to learn? Because it's quite different from normal hearing, isn't it?
It is incredible to see how quickly the brain learns to use electrical signals coming from the implant instead of signals coming from the ear itself. And whether you are young or old, the brain still has that ability to learn, which is absolutely incredible.
Wow, that's really, really fantastic. So, Susan, have you noticed through your work any of the what are the main changes you'd like to see for healthcare or for the researchers, for example? Is there any big changes that you'd like to sort of promote? I'd like to see health professionals to be sort of more aware to it, because I think even when there are interpreters booked, it can sort of be that they're feeding less information through the interpreter, and it might be that interpreters miss some of the information because they don't understand, or because it's a difficult conversation to have. And so I think the doctors need to be confident that they can tell the interpreter everything and it will be translated fully. So do you think they're not being transparent? Why not? I think sometimes it might be that they sort of see a deaf person and they think, oh, should I explain everything? Or I'll just explain just the bare minimum of what they need to know. And unfortunately, there are some people like that out there. Do you think that people assume deaf people aren't capable to understand? Yeah, I think so. And also just poor deaf awareness. So it's about how they receive that information. And it could be the culture of the health professional, you don't know. It could be about their education, how they view people with disabilities. Okay, so I'm going to change this topic a little bit. That was a very an example of poor service. What about fantastic services that you have an example of? We've had fantastic examples with oncologists. We had an elderly man who had dementia, and unfortunately his wife was unable to go to every appointment with him. But obviously he had dementia, so it was difficult for him to remember everything. But it was so good because his oncologist and his pool of interpreters actually gave permission and consent for them to record the discussions, with his consent of course, so that he could show his wife when he got home. And so she could say, right, let me see the phone, let me see the recording. So she actually was able to take in that information and support him with that, which was a fantastic example. Another great example is our referrals from health professionals have increased significantly. So we know that they're reaching out for us to support the clients. Okay, I've got another question for you, Susan. So you've got the good experiences and the bad experiences. I think it's good for everybody here, aware that, supporting BSL users. Have you got any good advice you'd like to pass on to Cancer Research UK at the Cambridge Centre so that they could take that on board with them? I think be open-minded. Listen to the deaf community. Include us in the discussions. That's it, really. like you said about creating BSL resources, I think that's brilliant. You know, we need some more because we're thirsty for more information. And as you know, there's over 200 types of cancer. We can't cover all of that, you know. We can cover the main, more commonly known breast cancer, cervical cancer, lung cancer, or prostate cancer, for example. But there's so many more.
Completely agree. For brain tumours, there are more than 130 different kinds of brain tumour alone. So the types of cancer are just the huge numbers of them, and that's definitely something that we really want to do. And one of the things we'd very much like to get from the deaf community is to work together with you to develop the signs that would help you to understand some of the bigger jargon pieces that might be held back by clinicians to this point. We'd also very much like to work with you. One of the biggest things that we have in the Cancer Centre is a really incredible patient and public engagement programme. And so it would be fantastic if there are people out there who are watching this evening who'd like to share their opinions, share their stories and experiences. Then there are emails that we can share through the Cambridgeshire Deaf Association. We'd love you to get involved. Tell us your stories, tell us how we can make it better for you, and help us to do that. So we'd love to work with you to be able to develop those resources and make sure that they're appropriate and beneficial for you. You're our priority, really.
Raj, would you like to add something to that?
Yeah, just to add to that, that might sound strange, but I think you could use deafness and deaf interpreters as your superpower in the clinic. By which I mean some of the best consultations I have had from the point of view of giving and receiving information and a really good understanding from both sides when things have been difficult have been with deaf patients. And there's a good reason for that. When doctors speak, speech is a very, very dense way of passing information. And you can plaster a patient very quickly with a huge amount of information, job done. But we know that patients in that way will remember, if you are lucky, 10% of what you're saying. And actually, by slowing down the interaction, you may end up getting better communication. And for me, that's been particularly when something was hard. There was something hard to work out between doctor and patient, and actually slowing everything down probably meant we got there better than if we had been going at full speed.
Fantastic. That's a great point as well. And from Claire, of course, today, one of the things I'd like to talk about is obviously the words related to cancer, because presenting today's live stream, I've been checking in with everybody, with Susan, and we're not sort of sure about some of the jargon. So as you say, sometimes we just need to create an almost glossary of terms. So we've got some comments, so I'll have a look on Facebook. So we've got a comment from Michelle saying so important. She agrees with the interpreters being key, and we need enough time to approach a deaf patient. As you said, it might take longer than normal, and that's so important. So if you've got any more comments or questions you'd like to submit, please do send them in, and now's your chance. Yeah, I'd like to add one more thing as well, so about the appointment times as well. It's another thing. I know doctors' time is so precious and it can overrun and be late for different appointments. One of the things that we face with interpreters, you can see on the screen, it will say, you know, the doctor's running 45 minutes late, for example. But one of the problems is that the interpreter might have literally only been booked for the 2 hours. And so you've potentially lost an entire hour with the interpreter just waiting, when you could have been seen by the doctor quickly so that the interpreter could be there for their booked time. And so I wonder if there's a way to sort of flag that actually, this patient is a deaf patient with an interpreter. I know it sounds cheeky, I know it's a big ask, but to sort of prioritise that, because then they have good time spent with the doctor and the interpreter. I agree, especially with cancer. You want to be able to be seen urgently, don't you?
We actually have done recently a patient experience survey which indicated exactly that quite often clinicians have an appointment with a deaf patient and it's not clear to them in advance that the person that they're going to be seeing is actually deaf. And we think that that's because that information is either perhaps not collected or it's not put in the right place within that patient's record, so it could be buried within several pages of information, and the doctor would have to read through all of that information to be able to find it out. And again, a simple change that we'd like to encourage clinicians to make is to put that information front and centre at the top of the patient's record, so that it highlights the fact that they are deaf, that they need an interpreter, and we can make sure through those means that services are improved, that, like you say, a deaf patient who has an interpreter present with him will be given the time at that allotted time to make sure they have the appropriate amount of time with the clinician.
Simple trick we use in the clinic is, if we have to have any type of interpreter, those slots are at the beginning of clinic or at the end of clinic, because those are the two times when you're more likely to be able to keep to time. A very simple thing. And so patients should ask for that and say, could I go at the beginning? Could I go at the end? I don't think anyone would be upset if you asked for that.
Ooh, that's a good tip. So, Claire, could you explain about the new Cancer Research Hospital and how it's going? Is there an update?
Yes. So we're really excited to have been granted the money to be able to build a dedicated cancer research hospital in Cambridge. The brilliant thing about it is that all patients who walk through the doors of that hospital will be offered the opportunity to take part in research trials, and I again suspect that that's something that the deaf community probably haven't been offered to this point. And again, the reason being that the information that's provided to somebody on a cancer research trial is about 30 pages of information, and it's an awful lot to understand. So, and very much black and white text. So we are trying to make it more accessible by including images, videos, and having them interpreted into British Sign Language. But one of the things we've been doing from the very beginning with the Cancer Research Hospital is including the community in the design of the hospital, and that has included some deaf advocates. So there will be things that have been built in from the very beginning, such as hearing loops, the provision of interpreters, excellent Wi-Fi service. All of that will be in the design features of it already. The exciting thing is that actually they've started breaking ground, so that means that they've started digging the foundations of the hospital, and we hope to open the doors to patients in 2029, I believe is the current plan.
Wow, fantastic. It's so important, and to know the sort of cultural awareness of the deaf community and their background. So it's nice that that's been thought of from that, like the base of the hospital as it is. Let's have a look and see if anyone's commented. Oh, Michelle again. She's asking about if the programme's available. Did we talk about the programme 5 minutes ago? What programme did we talk about? I'll go back a little bit. So talk about the new hospital. Have you seen other hospitals in the UK that you feel they understand about the deaf culture in the design of the hospital? Or? Not really. I mean, I don't know the history of different sort of cancer centres, for example, but clients do ask us if they've got a problem. And I think a lot of the cancer centres have been really efficient and able to quickly solve the problems, and they're not sort of faffing about as it is, you know, they're very keen on listening and very keen on being told what do we need to do to improve and actually reacting on that. And so, for example, the patient would then visit again and say, oh, actually, yeah, thank you. Gosh, they've actually listened to my feedback. Wow. So I wonder how would somebody refer to your service, Susan? So if they're wanting deaf cancer support. So we've been shouting from the rooftops, we are here. So we want health professionals to be aware of our services, of course, but we have our own website. So anytime you're sort of thinking, oh, actually, you know, what deaf cancer support is available, just search our service. It's deaf cancer support. We're there. We've got information on the website. We've got a referral form and we've got BSL videos, or you can upload your video and send it to us for what support you need. Brilliant. So the person themselves can refer? Yep, so it can be the person themselves or it could be the health professional, for example. Brilliant. So is there anything you'd like to add, either of you?
I think we're just coming back to Michelle's question about the programme. Was she referring to the patient programme, which is very much where we get the patients involved from the very beginning. So some of our patients have kind of offered to come on board and give advice and give their opinions on the types of research that we do, for example, the things that we might not have considered from a patient's perspective. So, for example, if we're designing a new study, is that study going to be comfortable for a patient to do? Is it something that's going to be a bit overwhelming for them? Like if they were to spend an hour inside of an MRI scan, would that be okay in order to advance the understanding around cancer and cancer treatments? So there's that side of things, and then there's also the side where we are working with patients to be able to produce documents, information, research reports, and having them then come and present at seminars and symposium to clinicians to give the patient voice to the clinicians and the researchers to be able to help them to understand why it is they're doing what they're doing. So it's a really powerful tool in reminding the researchers why it's important to do cancer research.
Brilliant. So have CDA worked with you for any sort of patient feedback? Are they going to do that soon?
Hopefully, yeah. So that's something we very much would like to do. And again, if you would like to offer feedback for anyone watching this evening, then we'd really value you getting in touch, and we'd like to do that. One of the other things we'd really like to do is to be able to provide opportunities for the deaf community to come and have a tour around maybe one of our labs, to have a look at what some of the research that's happening. We can do some engagement activities.
Oh, Susan, that should be so interesting.
Yeah, absolutely. So we can do some engagement activities that help explain what it is that we're doing in terms of research in a more accessible way. And we do those with children, we do them with the general population. And in fact, we've had a group out today doing some of that with a whole school, a primary school.
Oh, that'd be fantastic. Yeah, absolutely. Key, our community coordinator, would be thrilled to sort of work with you. She runs a number of different events, so that would suit us. I'm sure a lot of the community would be so interested. And Susan's definitely going to be there. I will be there as well. Yeah, absolutely. So have you got any last comments or anything you'd like to add? Oh,
I would say don't let paperwork put you off getting involved in research, because we know that being involved in research, if you've been diagnosed with cancer, helps you directly. Not only do you help answer questions about how to make cancer treatments better or pick up cancer earlier, but you get another team that look after you, because you'll have your medical team who are looking after you and giving you care, and you'll have the research team too. So it's an extra pair of ears who are listening in and are able to answer questions and give you time. So it's always a good idea, and I would be very sad if somebody was put off just by the paperwork, because in this day and age, that shouldn't really be a problem.
Absolutely agree. I think as well, paperwork can feel really overwhelming for the deaf community because obviously the structure of written English is being completely different to BSL language, as I'm sure you know. So if there is a way, is there like an adaptations that can be made so that the research involvement is more accessible? Could it be like delivered to them through an interpreter, for example? Because I think a lot of deaf people might be more keen to be involved in that way.
Absolutely. And it's one of the nice things about the Cancer Research Hospital, because the research involvement is baked into the way that it's designed. So there will be the kind of space and support that you need, so that if you want to know more about research, or you then want to fill in the paperwork to take part, then it should be available. I hope that by the time the Cancer Research Hospital opens in 2029, Claire,
So, yeah.
it won't be paperwork anymore. It will be something a little bit easier to manage.
Yes.
But right now it is still paperwork, but we're working on it. So yeah.
Brilliant. I think AI would have taken over completely by that time, hopefully. Is there anything you'd like to share with the audience, Claire, about how to find your website, what to do? Yes, so we've got a website, www.deafcancersupport.org.uk. So if you forget or you're not sure, get in touch with CDA and you can share. So yeah, we'll share all of their details. If you feel you've watched so far, you can pop your name in the comment. We can absolutely share the details with anybody who wants to be more involved. Also, I'd just like to add, it's so important, our service is completely confidential. So I know the deaf community is really small, and sometimes our patients don't want a volunteer they already know, so we'll pair them up with somebody who they don't know at all. That's really, really useful. Thank you for clarification. Susan, any last comments?
No, I think that's, yeah.
I just want to say a big thank you to all of the guests who are coming today, for sharing your knowledge, your experience and everything. It's been so interesting for me to learn new things. Thank you for Susan as well for coming for the Deaf Cancers. Thank you, Claire, and thank you, Raj. Hopefully you've all enjoyed watching. Thank you from CDA TV, and we will see you next month for another episode of the Cancer live stream. So we will see you soon.